Okay, Dr. Deuk Majan and the Deuk Spine Institute, wrapping up our last surgery of the day. It is late. We had some pretty complicated, difficult surgeries today. It took a lot of time. Anyway, this last one is going to be a Deuk laser disc repair, L4-5, L5-S1. Shot. And I'm trying to get around the shot. There it is. The L5-S1 facet into the L5-S1 disc. Shot. Shot. Hold on. Cannot see. AP. Shot. It's pretty good. It's about as good as we're going to get it. I'm going to make an incision. The incision is going to be a 1/4 inch incision, and we're going to place our second needle, aiming this time for the next disc up, which is L4-5. Lay still. Shot. You're doing great. Shot. Shot. Perfect. Shot. You're doing great. Doing great. Shot. All right, so for those of you watching, this surgery is going to actually be 2 separate procedures. One of them is a DPR, the other is a DLDR. Is he ready for a discogram? A little more?
Open your eyes for me.
How long has he had back pain for?
Want to tell us how long you had back pain for? Hey, how you doing, my friend? How many years you have the back pain for? You want to tell us? 20 years, he said.
All right, 20 years. Well, around 20 years. It's good enough. Is he reliable?
How are you, my friend? Can you open your eyes for me? Okay, we're going to ask you to give us a number, okay?
We may not get a great answer. Shot.
Can you open your eyes? Okay, good. That's perfect. We're
How,
going to ask you some question now, right?
already did. How bad is that on a scale of 1 to 10? I think he's still snoozing though.
You feeling any back pain? How bad is that on a scale of 1 to 10? What's your number? 0 to 10. 3? 4.
Well, right now I'm not doing it, so it's too late. Anyway, we're just going to proceed. Let's check 5-1. I don't know if I'm in the disc at 5-1, but let's see. Shot? All right, we are. Well, let's see. Give me an AP. I need the lights down a little bit. It's too bright in here. It's hard for me to see the monitor.
Yeah.
Come on.
There you go. There you go.
Oh, wow. Look at that. Beautiful. Both discs. That's so cool. We're going to start with 4-5.
Thank you.
Don't take it backward. That's 5-1. Yeah. Okay. So we're going to take questions, if you have it, from the audience. In the meantime, we're going to keep moving forward. But let's roll a video showing how do disc problems like herniated disc actually cause back pain. Shot? The answer is inflammation. And let's see how they cause inflammation. Shot?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, thanks for joining us. We're getting ready to start the L4-5 Deuk laser disc repair. That'll be the first one we're doing. Left approach on this patient who has really one degenerated disc and one herniated disc. If you look at the x-rays, you can actually see the L5-S1 disc is degenerated very badly, and the L4-5 disc is herniated. He's having severe pain. He's had it for 20 years. Laser. And he's tired of living with back pain. Found out about the Deuk laser disc repair and watched lots of our surgeries, learned about the procedure, and showed up to get his back fixed. That's what we're doing today. I expect with this surgery we're going to get rid of probably 95% of his back pain long term. That's based on results that we've had from prior surgeries. Our average is 95% at 6 years. Grab her. All right, we use a combination of laser and what's called mechanical debridement, where we're removing pieces of herniation. Remember, this is L4-5. We still have to do L5-S1. If you look here, these are all fragments of herniation. There's not just one piece, it's lots of pieces. And the beauty of this laser is that it actually helps me get rid of these pieces because it creates not just the energy that's delivered directly to the tissue from the glass tip. That energy is called electromagnetic radiation. There's a piece of herniation right there. See how it just wiggled itself out? We're going to see a lot of those at L4-5. L5-S1, on the other hand, is completely collapsed. Now we're treating L5-S1 because that's where a lot of his pain is. It's still coming from that degenerated disc at L5-S1. It's coming from the annular tear. How's he doing, doctor? Everything okay? Look at all these little snowballs coming out. All right. Let's get to the tear. You can see the tear right there. The white's annular fibers. The blue is the herniation inside the fibers, called interposed herniation. Let's show the audience just how the Deuk laser disc repair works to fix the annular tear and herniation.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, welcome back. Once again, this is a lumbar Deuk laser disc repair to treat a herniated disc and a degenerated disc that are causing back pain and left-sided leg symptoms like leg pain. The patient also has facet joint pain, left L5-S1, and we're going to be doing a Deuk plasma rhizotomy as soon as we're done with the discs to treat his facet pain. Today was a busy day for us. We started out with the 3-level cervical Deuk laser disc repair. That went very well. Then we did a 1-level, but unfortunately the 1-level, I was not able to complete the Deuk laser disc repair, and I had to just do a partial. And that patient, I just feel horrible about it, but it shows the fact that sometimes you're not able to do the surgery you set out to do. And it's not that we didn't have the equipment working or the staff. It's just sometimes surgeons get into the body and they find that the anatomy of the patient is not conducive to the surgery. There's no way you can know that ahead of time, at least not in this day and age, because everything was a green go until we got to the collarbone and found the collarbone was just, you know, millimeters too high. That's changed everything. Changed the angle of the tube. This tube you're looking at has a beginning and an end. The beginning point is important, the end point is important, and the whole path along the way is also important. But when the beginning is constrained, it changes where the end will be, and it changes the orientation of the end. So if your beginning can only go in a specific spot, and you can't put it where you want it most, then you're sort of stuck in terms of the angle of the end, or the position of the end, which is the business end of the tube, the end that you're seeing right now. It's really important that the end of the tube be exactly where you want it, and most importantly as well, not just where you want it, but oriented or angled in the way you want it angled. Think about a light, a flashlight, right? The light comes off the end of the flashlight, but if it's not pointed up, down, left, right, exactly where you want it, you won't see what you're looking for. So we were able to get the end of the flashlight kind of where it needed to be. However, I couldn't point it in the direction I needed to point it, and it was disappointing. It's not often we get a surgery that we cannot complete the way we want it. It's rare. Probably, I don't know, Luis, what do you think? 1 in 50, 1 in 100?
I believe 1 in 100.
1 in 100? About 1 in 100.
Yeah.
Don't really have an exact number for you, but about 1 out of every 100 surgeries, we just cannot complete it because of the patient's anatomy. And sometimes you can actually tell ahead of time, other times you can't. All right, this is the annular tear we're dealing with, and what you're seeing is pieces of herniation. This white stuff right here, I'm zapping. Those little pieces of herniated nucleus pulposus are actually sitting inside the annular fibers. I'll show it to you again, right here, right there. See that? They're like wedged in there because they're supposed to be in the center of the disc, but now they're stuck in the layers of the annulus that's torn. Huh? Can you see that? Everything okay, guys?
We can
All
see
right.
it.
We're
Yes.
just about done. I need about 1 minute.
We have a question.
Sure.
This comes from Ainsley on YouTube,
Yes, hi.
and they said, "How is the recovery for this procedure?"
Yeah, the recovery is amazing. This is the best spine surgery in the world for recovery. It's 1 hour recovery. And then you can walk out of here. You can go have dinner. We've even had one person go coach a basketball championship game, a coach of a basketball team that was in the finals. He had a surgery in the morning and was coaching basketball that night. He was a little sore, but surgery went great. Most people can go back to work the next day if they want to. Not manual labor work, of course, but you know, as long as you're not lifting heavy things, you can go back to work the next day. Certainly if you have a desk job. You may want to take a few days off. Some people decide they want to take 2 or 3 days off, but the recovery is usually just a few hours. This is outpatient surgery. This is not being done in a hospital. It's being done at the Surgery Center of Viera here in Melbourne, Florida. 1 minute. Once again, this is the L4-5 disc. We still have the L5-S1 disc to do. So these are like layers of a wedding cake right here. The annulus starts right here at the tip and it comes all the way out to here. And you can see the little veins. These are called epidural veins. They're part of Batson's plexus that we all learn about in medical school. And they're in the epidural space around just in front of the nerve root. So this is the annulus, and you can see it's been torn and there's pieces of herniation inside of it. And I'm just cleaning it up so it's going to heal better and not cause any pain. Great job, everyone. Just about done. I want to just shave a little more of this. Great question, by the way, from our audience. Thank you for asking. All right. Let's see the nerve, if we can see it. The nerve root is going to be right up here in this fat. I don't see it. It's covered by fat and veins and connective tissue, but that's where the herniation was. Let me do one more blast. That's it.
Lights on, please. Thank you.
Scope off. Little antiseptic. All right, how's he doing? Next is 5-1. What's that? Yeah. No, I talked to him about it before. He said he doesn't. He said he doesn't even use a CPAP machine for like a year.
Well, the fact that he has a CPAP machine and then you sedate someone in a prone position, sometimes it's good, sometimes it's bad.
No, I know. I just thought it was interesting. He doesn't even use his machine anymore. At least that's what they told me.
All right, my friend, just relax. You're doing great. Feeling num num?
Yeah, we'll do a num-num. Show us 5-1. All right, beautiful. So at this point, we are not quite in 5-1, and we're just sitting on the back side of the disc. And I was hoping that we could get our patient a little more sleepy, which Dr. Berndez has done. And then I'm going to make a run for that 5-1 disc and try to get in, because you can see it's bone on bone almost, and not much disc left. Shot. Go ahead. I'm right on the fascia. Yep, perfect. Good. Yep, that's good. Did you put some?
Yeah.
Yeah. So that's the more stimulating part right there. Shot. Okay, so now I'm bringing the dilator down to where that painful disc is. All right, shot. Yeah, he's not liking that at all. Hold on. Let's just wait for a minute. Tell me when you're ready, doctor, because I'm just about ready here. Go ahead and take the guide wire out. You tell me when you're ready. Shot.
There's a bunch of there.
So to be able to get into a disc like this at 5-1, which is already the hardest disc to get to already, and most surgeons won't even try. And then on top of that, it's collapsed, retrolesthesed, and there's spondylosis with bone spurs. You really need to sometimes force the tip down and in towards the middle. Should I go? And we've done that. So let's just hope this works. He is not liking it, but it is working. All right, so we're inside the disc. You can see we've spread those bones apart. And he's not happy about it. I don't blame him. You want me to wait?
Okay.
Let's see where the tip of the tube is. Now we've just got to get the tube in there. It's looking pretty good, almost. That's it, I felt it go. All right, we're good. So we're now inside the L5-S1 disc, and we're gonna go clean that thing out. Yeah, you're strong. Look at that, Luis. Oh, very nice. Yeah, almost done. Sorry, I know that's a bit uncomfortable. That's obviously still very painful. So the beauty of this surgery, for those of you watching, we're fixing not just a herniated disc at L4-5, but also a degenerated disc. Lay still. He's strapped in, right?
Oh, yeah.
All right, lay still. You're doing great. Everything's okay. So that was more stimulating for him.
There you go.
All right. So there's the disc right there, folks. He's moving. Yeah, I'll take the grabber. You guys see the disc?
Yes,
Pretty
we
cool,
do.
huh? All right, so not much disc left. Literally 90% gone. And what's left is just hurting the heck out of them. So the options for this would be fusion or laser disc repair. And I'm going to show you why the laser works. You guys see that thing at 12 o'clock?
Yes, we do.
All right. That little pink stuff at 12 o'clock is the source of his pain right there. Oh my God, I love it. Right there. Can you guys see that? Oh, you've got to get this. This is another one.
Yes.
Please, hold on. Let me just turn off the irrigation. Look how beautiful that is. That is where all of his pain is coming from. Can you get like 5 pictures? Just snap away. All right, keep going. One of these is going to be absolutely perfect. Maybe this one.
Copy that.
Good one?
Yep.
All right, that's granulation tissue. That is inflammatory tissue. It's like a big giant zit down there. Just pain all the time. Never going away. And now I use the laser to get rid of it. Believe it or not, the whole disc, all of that disc can be gone. None of that matters. It's not what's causing his pain. It's quite literally that little area of tissue at 12 o'clock. You get the laser on that. There's no other tool, by the way, that will remove that. I need 2 minutes here, and I'm done. Wow, look at all the blood supply in that area. Oh, yeah. That's been hurting for a while.
We have another question.
Yeah.
This comes once more from from Ainsley on YouTube,
Sure.
and they asked, what kind of anesthesia is used for this?
Well, we use something called MAC with propofol. It stands for monitored anesthetic care or monitored airway care. It's basically a mask around the face to deliver oxygen and also to monitor carbon dioxide that's being released, and of course monitoring the vitals. All right, I think we're done. We're done.
Lights on, please. Thank you. You guys here?
And then propofol sedation. So they're getting a sedative put in their vein, the patient is. It's called propofol, best you can do. There's drugs that can be used to put patients to sleep for twilight anesthesia. The very best is propofol. Of course, maybe 10 years from now it won't be. But propofol was introduced for me back in neurosurgery training around 97, 98. And it became very quickly the best drug to use for sedating patients, putting them to sleep, but not snowing them. And you can modulate the amount of anesthetic. This is clogged. Yeah, it's done. So propofol sedation is the best. That's what we use. So the patient can actually talk to us during the procedure, and we can ask them questions. For example, when we're doing the discogram, I want to know if it hurts. Today, the patient was a little, too sleepy to respond, and we proceeded with the discogram. We did a chromodiscogram rather than an evocative discogram. Not yet. All right, now we're going to move on to the next phase of treatment, which is going to be the Deuk plasma rhizotomy. This patient has facet joint pain at L5-S1 shot, and my intention is to treat that facet joint pain with our plasma rhizotomy, which is a rhizotomy procedure designed to eliminate facet pain. Coker? Hold on a second. Yeah, Coker. Never. All right, Jordan, shot. All right, good. So show us our target, Jordan, so the audience can see. That is correct. You see that right there, Henry? That is our target. Are you there, Henry?
Yes, we see it.
All right. Go on, shot.
Yeah.
Shot. All right, that feels pretty damn good. Shot. That's perfect. Wait. Right. Hold on. Shot. Right there. Absolutely perfect. That's where the transverse process meets the superior articular process and the pedicle. Nice. All right. Blood pressure is good?
Yep.
Hold on. Shot. Okay. Hold on. That's all me. Interesting. Shot. Perfect trajectory on the AP view. There we go. Hold on. Let's see where we are here. Shot. A little too low. That's feeling good. Shot. That's too low. That's feeling good. Shot. Too medial. Shot. Too medial. Shot. That's too superior. That's right. Shot. Let's see where that is. Too lateral. Shot. Too lateral. Shot. Too inferior. That feels pretty good. Shot. That's perfect. Let's see where this is. Sean? So this procedure is quite unique in that it's basically a rhizotomy where we're deadening the pain nerves, and it's done with a electrocautery probe. And the reason we do it this way is that we find the results are better. They last longer. Shot. Shot. It does take a little fidgeting to get to where you need to be. That should do that. And we got to do the S1. Watch your hand. Shot. No, too low. Show us the target. That's correct. Shot. Trying to get there to join you. There it is. Shot. All right. Let's do it. It really wasn't the collar. It was actually the panel that was the problem. You know what, Luis? It was this. It was just caught on the fascia. Believe it or not. Normally it's not a problem. Any questions from our audience? Shot?
No current questions, but we do have 2 comments. This first one, it comes from Justice on YouTube.
Okay. Hi, Justice.
And they said, I can't wait to watch my own video as soon as Texas Workers' Comp approves my surgery.
I pray for you that it does.
And then
I
the
really
next...
do.
Oh, I apologize.
No, I said I really hope they do. I don't know if does Justice have another name?
Justice... their last name, I think, is...
Do they use a different name on YouTube?
No, it's
Oh,
just
okay.
Justice.
Yeah, because I just saw another comment posted on one of our videos from another work comp patient, Sean, and that patient was talking about Texas work comp as well.
Oh.
And I responded to them.
Alrighty.
So, just about done.
And this last comment comes from...
Sean,
Oh.
Go ahead.
This last comment comes from Canes25. They said, quite a long day, Doc. You deserve some Mexican food.
Thank you. Thank you, Haynes25. I appreciate that. You know, maybe I'll get it. I hope so. You know, for me, though, I'll be honest with you. What I love the most, without exception, is curing pain that people have for years, getting them pain-free, getting rid of their back or neck pain, getting rid of the arm or leg symptoms. That's what drives me every day to keep going, knowing that I'm doing something special for people to improve their quality of their life so they can enjoy life with their friends, their family, themselves. That's special. And that's what I think drives all of us here. I know these people don't work here because of me. They work because they love helping people. So, and we do a pretty good job of doing that. So, thank you. I do look forward to having some good Mexican food, though.
Before we go, we do have one last question. This comes from Ainsley, once more on YouTube, asking, was there some sort of complication with this part?
Oh, there was no complication that I'm aware of. With this part, no, the surgery went very well. We did 2 things. We did the Deuk laser disc repair at L4-5 for a herniated disc, and then L5-S1 for a degenerated disc that were both causing back pain. And then we did what's called the Deuk plasma rhizotomy at L5-S1, where we were treating the facet joint pain. The facet joint is behind the disc. And I had to deaden the nerves at the L5 transverse process and the S1, right where the facet joint is. We call it a rhizotomy. And we just finished that, and that went very well. So no complications that I'm aware of. And let's hope it stays that way. All right, any other questions?
No current questions. This last comment comes from Justice that goes by the name of Charles Henry Meyer III.
Oh, okay, very good. Nice to talk to you, and I hope we can help you. All right, have a good night, everyone. We'll see you Friday. We'll be broadcasting this Friday in the morning. Not Thursday because I'll be out, but we'll do it Friday morning.